Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by SB Bangladesh chapter and supported by Bangladesh Society of Medicine. Today, we have come to the 7th episode of our series. On this episode, we are going to talk about another very important topic. Today's topic is about acute pneumonia. To talk about this important topic, we have our governor of SB Bangladesh chapter himself, one of the best physician of our country, Professor H.A.M. Nazmul Ahasan sir. He is the former president of Bangladesh Society of Medicine. To chair the session, we have the legend himself. He is none other than Professor Kaji Tariqul Islam sir. He is the former governor of SB Bangladesh chapter and also the former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, we have Professor Rajibul Alam sir. He is a professor of medicine at Anar Khan Modern Medical College. We also have every student's favorite professor, Professor M.D. Zakir Hussain sir. He is the professor of medicine, TMSS Medical College, and founder chairperson of Hypertension and Research Center, Bogora. To moderate today's program, we have Dr. Muhammad Mahfuzul Haq sir. He is the assistant professor of medicine, Dhaka Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Muhammad Mahfuzul Haq sir. Dr. Muhammad Mahfuzul Haq sir.
Thank you very much, Dr. Prince Kausar. Good evening and welcome you all to this the health talk. And we have got very renowned speaker today, as mentioned by Dr. Prince Kausar. That is our very renowned professor, A.M. Nazmul Ahasan sir. And I would like to tell you that our very renowned Professor Tariqul Islam sir, former governor of SCP Bangladesh chapter, will be chairing this session. And Professor Muhammad Rajibul Alam sir and Professor Muhammad Zakir Hussain sir will be present as a panelist. I think before the start of the FCPS exam and other exam settings, this session will be very important for all trainee doctor. And I also want to mention that this topic is very important, not only for this COVID era, but also before the COVID era. The pneumonia is the commonest cause of hospitalization due to infection. And even after the start of the COVID era, the pneumonia is important. Not only the COVID pneumonia, but also the bacterial pneumonia is also an important cause. We have to understand this topic. We have to manage this topic. We have to answer in the exam setting as well. So I don't want to kill the time. I want to directly go to our very renowned speaker, Professor A.M. Nazmul Ahasan sir, and may I request sir to start his presentation.
Thank you, Dr. Mahfuz. Dr. Prince, am I audible?
Yes, sir.
Thank you, Dr. Mahfuz, for your good introduction. Honorable Chairperson, who is also past governor and also past president, Bangladesh Society of Medicine, currently advisor and professor of medicine of Popular Medical College, and also holding many other portfolios. I am honored to get one topic to present at this platform that is organized by Bangladesh, SCP chapter Bangladesh, as Health Talk on Acute Medicine. And that's why possibly our organizer of this time, Professor Rubina Yasmin, who is professor of medicine, also head of the Department of Medicine of Mugda Medical College. She is actually organizing this health talk. and she has asked me to present this topic, and she has given this topic acute pneumonia. I was initially a bit hesitant. What is acute pneumonia? Is there any chronic pneumonia? But pneumonia, this is definitely an acute. I am also happy. Two important colleague of mine, Professor Rajibul Alam and Professor Zakir Hussain, they are very renowned professors of medicine and contributing in health part of Bangladesh for last 3 or 4 decades. I will tell regarding pneumonia. And although we are organizing this acute health program and different programs, we are definitely supported by Bangladesh Society of Medicine, because we are the same person working in different platforms at different times. Just 2 days back, I had an opportunity to present on a class of OSPI, which is organized by Medexcel. That is chief coordinator is Professor Khan Abdul Kalam Azad. So I want to start. Our lungs, different organ has different functions. We have 2 lungs in the chest. Main function of lungs is to carry oxygen to exchange this air from environment and purify, we can say simply, and this oxygen is then carried to different tissues. You see this forest, this is Amazon forest. This is the largest rainforest of the globe. আমি মাঝে মাঝে ইংরেজি মাঝে মাঝে বাংলা বলতে চাই যাতে আমাদের মনের exchange of views and emotions আমরা যাতে বলতে পারি. So Amazon, this is the largest rainforest of the globe, and it is situated at the northern part of South America, mainly in Brazil and also Colombia, Bolivia. So possibly 9 countries, they are actually sharing this, and it is famous for different reasons. A lot পূর্বে যখন ওয়াইল্ড ফায়ার বিভিন্ন অ্যামাজন ফরেস্টে যখন অনেক গাছ পড়ে যাচ্ছিল, সারা পৃথিবীর থেকে অনেক এনভায়রনমেন্ট স্পেশালিস্ট তারা কিন্তু সারা বিভিন্ন আন্দোলন করতেছিল যে এটার জন্য. So this is very important, playing an important role. Similarly, our lungs is playing a very important role. So pneumonia, this is a very, Dr. Mahfouz, he has rightly said that pneumonia is a very common topic, very old topic, and many people die due to pneumonia. That's why it is called that friend of elderly. So I want to now start from some basic part. I think some listeners, they are students, undergraduate, there are some postgraduate students. So pneumonia, while we were a student, pneumonia was defined as solidification of lung parenchyma. But now it is currently said as acute lower respiratory illness, which is associated with recently developed pulmonary shadowing. So this acute lower respiratory infection with radiological changes, this is called pneumonia. And similar terminology is also very well known, that is bronchopneumonia. Bronchopneumonia is said to be bilateral lobular pneumonia. So in addition to alveoli, there is inflammation of bronchial mucosa and also bronchial tree. So this is bilateral lobular pneumonia, is called bronchopneumonia. So if we classify pneumonia in different ways, it will be helpful to understand the topic and subject, and also to diagnose and manage. So why I am trying to classify in different ways, it will be possible to understand at the end. So it can be classified in different ways, like anatomical classification on the basis of pathogen causing pneumonia, how it is acquired from the environment or the hospital, etiological classification, pneumonia in special situation, depending on clinical severity. So in defined ways, we can classify pneumonia. So anatomical classification is simple. So this is lobar pneumonia. The terminology simply simplifies that when one lobe is affected, this is lobar pneumonia. Sometimes it is lobular, it may be segmental. So bronchopneumonia is bilateral. So when there is bilateral lobular pneumonia, this is called bronchopneumonia. So classical pneumonia is lobar pneumonia. So when we say pneumonia, if we do not say lobar pneumonia, it means that it is lobar pneumonia. So classical pneumonia is lobar pneumonia. So if we classify according to organism, it can be bacterial, it can be viral, it can be fungal. So there are so important bacterial organisms are Streptococcus pneumoniae. So pneumococcus is considered to be the important bacterial pneumonia, but it may be sometimes other bacteria like Staphylococcus, Klebsiella, Haemophilus. There are some other organisms which are also very common, which can cause pneumonia, like Mycoplasma, Chlamydia, Legionella. So these are organisms which sometimes include nowadays viral pneumonias, fungal pneumonias. They are upcoming also. So this is also very important role, playing role. Classification on the basis of acquiring infection, we can classify as community acquired pneumonia. If it can be as hospital acquired pneumonia, it can be again divided in early hospital acquired pneumonia, late hospital acquired pneumonia, even ventilator associated pneumonia. It can be also early ventilator associated pneumonia, late ventilator associated pneumonia, healthcare associated pneumonia. So depending on acquiring infection, pneumonia can be caused. So it helps to know what is the organism, how investigation will be done with the prognosis, what antibiotic we will choose. So in most of the situation, diagnosis is not that much difficult, but to identify the organism is very difficult, and what antibiotic we have to choose, this is sometimes very difficult. So this is also sometimes very difficult. So if a patient comes with as a community acquired pneumonia, Streptococcus pneumoniae, Mycoplasma, Legionella, these are the chlamydia, these are the commonest causes of community acquired pneumonia. In case of hospital acquired pneumonia, Staphylococcus and gram-negative organisms, these are the common organisms. In ventilator, in ICU, the organisms are much more notorious. So depending if the pathogenic organism causing the pneumonia, we can say as primary pneumonia. So the pneumonia may be primary pneumonia, or sometimes some underlying disease may be superimposed by pneumonia, like one immunocompromised patient sometimes may develop pneumonia secondary to his own disease. This is secondary pneumonia. We have the knowledge of pathology. Classically, there are 4 stages of pneumonia. That is stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution. So within first 24 hours of pneumonia, there is increased vascularity at the affected part. There may be increased circulation leading to red hepatization, and finally the area becomes solid like a liver. That's why it is called gray hepatization, and it will persist for 4 to 6 days. So total period is around a week, and then if the patient is treated well, then the area there is resolution of patient improves. So this pathology, this is classical in case of lobar pneumonia. So initially there is increased vascularity, circulation, then there is the WBC then enters into the area and removes the degraded products. This is gray hepatization and resolution. So this is the time period, and also the picture shows how pneumonia develops in a patient. Regarding community acquired pneumonia, it is commonly caused by Streptococcus pneumoniae, and it is mostly droplet, spreads by droplet infection. So that's why during large gatherings, sometimes vaccination against this pneumococcus is usually given, and when from different countries, pilgrims like for Umrah and Hajj, they go to Saudi Arabia, they are uh, said to take different vaccines like pneumococcal vaccine, influenza vaccine, and also Haemophilus meningococcus vaccines. There are different factors of patients and sometimes environments which may lead to this community acquired pneumonia. So those persons having asthma, those persons having some immunocompromised disease, they are likely to develop pneumonia. But there are some healthy people that sometimes may develop pneumonia. There are so cigarette smoking, alcohol, these also sometimes predispose to pneumonia. So classically, in community acquired pneumonia, the onset is very sudden. So suddenly the fever shoots. It becomes 103 or 104 with this. For the first day, like dengue fever, the patient develops fever and it becomes 103, 104. So if this fever persists for 5, 6, 7 days, and patient is having cough, this is initially dry cough, but it is painful. So classically, the fever, there is chest pain, and it is pneumonia is usually unilateral pneumonia, and there is pleuritic chest pain. So this pleuritic chest pain is very classical for pneumonia. So pleuritic chest pain, when a patient presents with pleuritic chest pain, there are 3 or 4 diseases we have to consider. One is pneumonia, and sometimes in case of tuberculosis, sometimes in case of bronchogenic carcinoma, even pulmonary infarction. So parietal pleura must be involved when there is pleuritic chest pain. Sometimes a patient may complain of pain at the right shoulder. So if a patient of pneumonia complains of it indicates that the diaphragm basal pleura is involved. So when sometimes when there is pain at the shoulder, either there is pathology above the diaphragm, or sometimes it may be below the diaphragm. So these are classical features. So in case of pneumonia, classically in lobar pneumonia, if we examine such a patient, we have to start with general examination. So sometimes there may be herpes, in addition to fever and increased pulse rate, sometimes there may be herpes labialis. So these herpes labialis, this is a simple clinical sign, but indicates that the patient is having lobar pneumonia and likely to be due to pneumococcus and likely to be respond to antibiotics. So this is a good sign. So what are the underlying diseases which may lead to herpes labialis? This is very good. Sometimes even due to malaria in case of urinary tract infection, simple flu, so it may lead to herpes. So herpes labialis is one of the important clinical signs of lobar pneumonia. Respiratory rate is increased. So this is one of the very important clinical sign in general examination or respiratory system examination. We look for respiratory rate. So this is a bad prognostic sign also. If we examine the patient, inspection, palpation, percussion, and auscultation, there is unilateral movement of restriction, trachea is central, and percussion note is impaired, breath sound is bronchial, and sometimes vocal resonance and tremulous is increased. There may be capitation at the early part and also during resolution. Sometimes there may be pleural rub. So when there is pleural rub, usually there is pleuritic chest pain. So these are the important clinical signs during examination of chest. But we have to examine the other systems also, because there are some pneumonia, which have other systems also involvement. So it may be multi-organ involvement also. So hospital-acquired pneumonia, it occurs when a patient is admitted in the hospital. If he develops pneumonia after 2 days of admission due to other diseases, it is thought to be hospital-acquired because it is important because organism, I have mentioned that usually it may be staphylococcus or anaerobic organism or gram-negative organisms. So there are factors predisposing like reduced host defense. Sometimes there may be aspiration. Sometimes bacteria may be introduced into the lower respiratory tract due to endotracheal intubation or other procedures, or sometimes bacteremia. So these are the factors which may lead to hospital-acquired pneumonia. So pneumonia diagnosis is not that much difficult because some investigations like simple WBC count is also very important. Usually we get leukocytosis, but in case of some forms of pneumonia caused by virus or mycoplasma or chlamydia, count may be normal, or sometimes there may be leukopenia, which is also a bad prognostic sign. Sputum is usually not productive, but if it is possible, gram staining, and always we do AFB stain culture. These are very important tools. X-ray radiology, X-ray is very important in case of diagnosis of all respiratory diseases. It is required to do chest X-ray for confirmation of diagnosis. Sometimes there may be early detection of complication because sometimes there may be parapneumonic effusion, and for follow-up. There are some other investigations. If blood culture shows that there is pneumococcus in the blood, so if there is bacteremia, it is very almost certain that it indicates the organism. There are some serological tests which also sometimes possible, like urine antigen for pneumococcus, Legionella. This can be also possible to identify the organisms. Sometimes in case of mycoplasma, cold agglutination test also possible. Blood gas analysis, so this can be done. And if required by if one patient or a physician wants, he can do also CT. So these are the investigations which are helpful. These are the some anatomical distribution, how we can say this is lower, middle, upper lobe involvement or middle lobe. So 2 days earlier we had a class on OSPE. We encountered defined excess. So this is from PA view we can say which zone is affected, upper zone, mid zone, lower zone. But if we want to see the lobe involvement, we have to do lateral lobe. So there are on the right side there is oblique fissure and there is a transverse fissure which differentiates upper lobe from middle lobe, and on the left side there is one fissure only, and which divides the upper lobe from the lower lobe. So lower lobe is below and behind, upper lobe is above and superiorly above and in front. So this is a fine fissure that is oblique fissure. That is, it is if we draw a line above and behind through the hilus of the lung, the area below and behind is lower lobe. So in case of left lung, it is possible to identify which lobe is affected. So this is one X-ray, possibly this is upper lobe involvement. In this patient, this is middle lobe involvement in this patient. This is middle lobe. The cardiac shadow is obliterated, but diaphragm is it is easily seen. So these are the ways. So lateral X-ray, this is very important for identifying which segment is affected. And this is upper zone is affected, but diaphragm is clear. So this is possibly on the left side, and this upper zone is affected, middle zone, and upper lobe is likely to be involved. On lateral X-ray showing that this upper lobe is affected. So these are other some examples. So we always consider some differential diagnosis. This differential diagnosis, this is taken from book, but always we consider sometimes tuberculosis, infarction, bronchogenic carcinoma. But for a clinician, when a patient presents with fever for 5 days or 6 days, we do not consider bronchogenic carcinoma. For pulmonary infarction, there is usually a setting. Tuberculosis usually is long. So it is not difficult to diagnose pneumonia if we consider three important clinical symptoms like fever, sudden onset of fever, and dry cough, and when there is pleuritic chest pain. And if we examine carefully, sometimes we get chest findings. So pneumonia diagnosis, it is not that much difficult from symptoms and signs. So regarding management, we have to consider whether it is mild, moderate, or severe forms. That's why we have to classify in that way also. So early administration antibiotic is very important. So confirmation of pneumonia with X-ray and antibiotic administration should occur during the first 24 hours to avoid any complications. So oral antibiotics, it can be given in case of community-acquired pneumonia, in case of mild forms. But in case of severe forms, in 30 to 50% of the patients admitted in hospital, they require injectable antibiotics. What are the indications of injectable antibiotics? When there is severe pneumonia, when there is loss of swallowing reflex, when there is impaired absorption, when their consciousness is less, in that situation we are to give injectable antibiotics. How long we are to give antibiotics, there is no consensus, but usually in case of mild cases, when it is uncomplicated pneumonia, it is 7 days is sufficient. But in case of some unidentified cases, it can be given 2 weeks. But in case of Legionella, staphylococcal, or gram-negative, we have to continue for even 3 weeks. So the duration may vary from first 1 week to 3 weeks. In case of uncomplicated community-acquired pneumonia, in books it is written as amoxicillin 500 milligram 8 hourly orally, but hardly we use amoxicillin nowadays. Almost not that much available also, but amoxicillin we can give in this case. But if staphylococcus is suspected, we have to give flucloxacillin. But in case of other mycoplasma, legionella, or in other cases, macrolides like clarithromycin is to be given. But in case of severe community-acquired pneumonia, clarithromycin intravenous plus cotrimoxazole or coamoxiclav or ceftriaxone or cefuroxime, this is to be given. Other adjunctive like hydration or for pleural pain, we have to give any analgesics. Sometimes oxygen may be required. So this is taken from the picture. This picture is taken from the books. Which antibiotic is to be given for what microorganisms. So knowing the microorganisms is very important. We can divide the complications under different headlines, like complications in the lungs. It may be lung abscess, but in case of pleura, it may be pleural effusion or empyema, or sometimes there may be respiratory failure or any systemic complications. A few days earlier, Professor Titomia, he gave a presentation on septicemia and septic shock. In one slide, he have shown that in case of sepsis and septic shock in our country, pneumonia is the #1 cause. So pneumonia is one of the important cause of sepsis and septic shock and ICU admission. So there are sometimes there may be a multi-organ failure. Lack of response to antibiotic, this is called delayed resolution. So there are defined overwhelming infection due to defined causes or incorrect diagnosis. This may lead to lack of response or delayed resolution. Usually, in case of what are the indicators that the patient is going to improve, usually within 3 to 4 days, the patient fever usually subsides. Respiratory rate usually becomes normal. If we do blood count, leukocytosis usually it comes to normal. So there are some indicators. But if the fever continues, if toxemia continues, if the respiratory rate increases, so we have to think that the patient is not improving. So delayed resolution, this is very important to know. There are, if the antibiotic is incorrect antibiotic, we have to know about the organism. It is not appropriately given. If the diagnosis is incorrect, if it is tuberculosis, it is infection or the malignancy, or there may be associated complications like empyema. So in that case, the patient unlikely to improve. So these are the conditions or headlines we have to think when the patient is not improving. Sometimes pneumonia can recur in a patient. Sometimes as a patient may develop pneumonia repeatedly. So if a patient develops repeatedly, possibly the patient is immunocompromised. So there are different diseases or drugs which may lead to immunocompromised conditions. But sometimes pneumonia can occur in on same lung, sometimes even same segment also. So we have to think, so if the same segment is involved, there may be bronchiectasis, or there may be a foreign body in the lumen of the bronchus, or sometimes even bronchial adenoma. So if there is recurrent pneumonia in same segment, same lung, or a patient is having recurrent pneumonia, we have to think. Radiographic improvement usually lags behind clinical improvement. So clinical improvement actually precedes radiological improvement. So we can do follow-up X-ray, but in some mild and moderate cases, usually it is not required. In cases of pneumonia, this vaccination against influenza and pneumococcus, this is very important. It has been found that if influenza vaccination is given in patients with pneumonia, when it is indicated, and it is possible to prevent pneumonia in many patients. So there are indications of giving influenza vaccines, and there are also pneumococcal vaccines which are also given. There are also some indications. So these two vaccines, which are very important for prophylaxis of pneumonia. I will rapidly go through some specific types of pneumonia. This is also very important because this staphylococcal pneumonia, it occurs two extremes of age, in young and in elderly. After an influenza, these patients may develop staphylococcal pneumonia. That's why influenza vaccine is very important to prevent different types of pneumonia. This staphylococcal pneumonia, this can also develop after bacteremia also. So this staphylococcal, this is a serious disease. Sometimes there it may be bilateral and abscess formation and shock. This is very important. For staphylococcal pneumonia, flucloxacillin, this is very important, and we have to give for a prolonged period. These are the complications which can develop in case of staphylococcal pneumonia. Klebsiella pneumonia, this is another important disease and severe forms of pneumonia. It occurs in elderly person, malnutrition, and alcoholics, and some usually required. Mycoplasma pneumonia is spread from person to person. Respiratory secretions expelled during bouts of coughing and sneezing, it is spread. So in case of 1/3 of pneumonia, it has been found that this is mycoplasma. So this is one of the common forms of mycoplasma pneumonia, and patient may have symptoms like malaise, sore throat, and myalgia. So mycoplasma pneumonia, this is one picture of pneumonia in this form. Sometimes agglutination, code agglutinin of 1:332 titer is very diagnostic of. Sometimes PCR can be taken as one of the investigation tool. In case of Mycoplasma, Legionella, macrolides like erythromycin or thiamycin, this is usually given. So these are the drugs which are given for Mycoplasma or Legionella. Legionella is another organism which is acquired by inhalation of aerosolized water, like humidifiers or shower heads or respiratory therapy equipments. So this may sometimes lead to development of Legionella pneumonia. In case of Legionella pneumonia, there may be some associated gastrointestinal symptoms, sometimes electrolyte disturbance. So this sometimes other non-respiratory symptoms may be present in case of Legionella pneumonia. This is one chest X-ray of Legionella. So serological test sometimes helps in diagnosing this pneumonia. And again, this erythromycin or clarithromycin can give. Fungal pneumonia, nowadays, this is a hot topic now. After COVID, this aspergillosis, mucormycosis, also candidiasis are becoming upcoming as important cause of pneumonia. Viral pneumonia is very popular now. Bird flu, SARS, SARS-CoV-1, MARS, and nowadays we are encountering this COVID. So how to differentiate viral pneumonia from bacterial pneumonia? In case of viral pneumonia, constitutional symptoms are more important than respiratory symptoms. The spleen sometimes may be palpable. If you do count, sometimes there may be a normal WBC count, and sometimes even there may be leukopenia. Uh, this is the same symptoms of COVID. One example of viral pneumonia, the mild, moderate, severe, critical. We know, uh, I believe that every one of you have encountered many presentations of COVID, like ground glass, HRCT showing crazy paving, and this vascular dilatation, bronchiectasis, subpleural bands. So within a very few hours, the lungs is involved. Within 24 hours, bilateral involvement, and within 2 to 3 days, patient becomes severely ill. I have mentioned that this primary pneumonia and secondary pneumonia, these are two important classifications. Sometimes pathogenic organism can lead to primary pneumonia, but sometimes due to other organism, other disease may predispose to pneumonia. This is called secondary pneumonia. So pneumonia caused by some low virulent organism sometimes may produce pneumonia. Pneumonia in a special situation like aspiration pneumonia, suppurative pneumonia, or lung abscess. In case of community acquired pneumonia, is patient is treated at adequate time with adequate dose and duration, this lung pathology becomes normal. But in case of suppurative pneumonia, there is destruction of lung parenchyma with microabscess formation. And when there is microabscess formation, sometimes they may coalesce together, may lead to a large lung abscess. So a suppurative pneumonia, usually it may be due to anaerobic organism or maybe aerobic organism. Anaerobic organism are either bacteria or streptococci, anaerobic streptococci, and organisms which pyogenic organisms are staphylococcus or gram-negative organisms. So I will not go in details of this. In case of suppurative pneumonia, cough with purulent sputum is classical. So the patient complains of profuse purulent sputum. Sometimes when it is due to anaerobic organism, there may be foul smelling. So foul smelling sputum is called fetid sputum. There may be hemoptysis also. So digital clubbing is one of the important differentiating point. So these are the complications of suppurative pneumonia. So diagnosis is usually not difficult because this cavitary lung and with the horizontal fluid level is very hallmark of lung abscess. Management usually 4 to 6 weeks antibiotic therapy is required usually. So medical treatment is antibiotic, and sometimes metronidazole we need have to be given. And postural drainage at least 50 to 20 minutes, 2 to 3 times a day is very important. Sometimes there may be failure of medical treatment may lead to surgical treatment. So the failure of treatment, sometimes patient may uh, develop profuse hemoptysis, and sometimes patient may be cachectic. So monitoring the foulness of the sputum usually decreases, fever subsides, patient's sense of well-being develops, cavity decreases. But these are the bad prognostic signs. So the bad when the duration is more than 3 months, or when the cavity is more than 6 centimeters, abscess in lower lobes, these are the bad prognostic signs in case of lung abscess. So there are three headlines, that is postural drainage, medical treatment, and surgical treatment. These are the sub for in case of lung abscess. So pneumonia in immunocompromised patient, this is another serious form of illness. I will not go in details of this. Severe community acquired pneumonia, this is very important. Since my topic is acute pneumonia, I want to run a few slides on severe pneumonia. When in 10% of the patients of community acquired pneumonia, they may develop shock and respiratory failure. So factors that may lead to community severe pneumonia is advanced age, sometimes other comorbidities, immunocompromised patients. So this may lead to pneumonia. So organisms commonly lead to severe pneumonia. One is the Streptococcus pneumoniae, Staphylococcus, Legionella, and gram-negative organisms. Uh, and a number of prediction rules have been developed by different organisms like pneumonia severity index, CAP 65, CAP 65 without urea level, SMART COP score. So there are different scores to identify which is severe pneumonia. So then this is the pneumonia severity index and used by different organisms. Two major important criteria is septic shock and respiratory failure, but there are some minor criteria. In different countries, they follow some guidelines, but in our country, unfortunately, we do not usually want to follow defined guidelines. We have many good national guidelines. Look, this is one British Thoracic Society severity assessment pneumonia at the community level. So they have developed one assessment tool for community level, one for hospital level. So this usually a classical form of CAP 65 score, which is used to assessment of disease severity in case of community acquired pneumonia. We know it. But regarding biomarkers of pneumonia severity, count is very important. Blood urea, sometimes hyponatremia, hypoalbuminemia, bacteremia, these are considered. And another important is procalcitonin. In case of moderate and severe forms of pneumonia, British Thoracic, there are different guidelines. So severe pneumonia, this is very important. We have to know that whether the pneumonia is mild or moderate or severe pneumonia. Severe pneumonia prognosis is not favorable. So we have to identify that this pneumonia is severe. So antibiotic pneumonia for severe community acquired pneumonia in patients without suspicion or microbiological evidence of the penicillin or an MRSA, that is methicillin resistant Staphylococcus aureus, IV combination therapy with a ceftriaxone plus a macrolide can be given. Alternatively, fluoroquinolone can be like levofloxacin or mefloxacin also can be given. But if Pseudomonas is suspected, then combination is to be changed like penicillin, tazobactam, or meropenem or ceftriaxone plus ciprofloxacin. So sometimes empiric therapy we have to give in case of patients with pneumonia. I tried to make 2 stations in case, in case of FCPS, IOE, there are 5 stations. Station 1 is emergency diagnosis. Station 2 is emergency management. So pneumonia, this is a one disease which can be placed in two stations. Like this, a 67-year-old man presenting with right-sided chest pain, fever, cough. What can be the differential diagnosis? How can you elaborate the symptoms? What science will look for? What investigations will do? How will you do microbiome? So it can be arranged in this way. So if again same patient, if this investigation is shown, in treatment you will start first, how will you monitor, what antibiotic you will give, how will you assess prognosis, what are the criteria of sending the patient to ICU. So in this way, this emergency first station 1 and station 2, this can be arranged. In conclusion, Mr. Chairman and other respected panelists, I want to conclude in this way. Pneumonia is a very common disease and an old illness. It can be caused by different comorbidities. Pneumonia is a friend of elderly. Diagnosis is, in most of the situation, is not that difficult, but we need to know the organisms because it depends on the success of treatment depends on the organisms and duration of treatment. Delay in diagnosis sometimes may lead to many complications. Immunization against some common organisms sometimes very helpful. I want to acknowledge with thanks to Professor Rubina Yasmin. She is actually organizing this platform, that is acute health talk, this health talk on acute medicine. She is professor and head of the department of the medical college. I am thankful to her. Thank you, Mr. Chairman and panelists and moderators. I'm thankful for advisory council members of ACP and EC DSM for cooperating. Dr. Fuad, Dr. Samin, Dr. Prince, many doctors helped me for making these slides and other logistic. Thank you, listeners and viewers, for your patience and hearing. Thank you very much.
Thank you so much for this short but very informative and very interesting presentation. I can see the whole comment section filled with many questions. Now it's time for the question and answer session. We firstly apologize because we won't be able to answer all the questions. We'll select few as the time is short. So, without doing any further delay, let me hand over the session to start the question answer session to Dr. Muhammad Mahfuzul Haq sir. Dr. Muhammad Mahfuzul Haq sir.
Thank you, Dr. Prince Kausan. So, thank you, our Professor S.M. Nazmul Ahasan sir. He has actually touched all the corner of the topic, and as we know, this is a very vast topic. And still, he has mentioned and touched all the corner. So, but to me, actually, there is no actually no space to ask any question. Actually, however, we want to take a few questions from the audience, and everyone is welcome and can feel free to ask questions.
Dr. Mahfuz, have you asked me any question?
So we can take a question. What will be the prognostic marker in an elderly patient with neutropenic sepsis due to severe pneumonia? So he has asked regarding the prognostic marker if the patient has the neutropenia and pneumonia.
The scenario is, you see, the patient is neutropenic, patient is immunocompromised. Definitely in this situation, in most of the situation, prognosis is not that much favorable. But if we can choose appropriate antibiotic, you can identify the organism. In many situations, prognosis is not that much worse, because if you start a susceptible antibiotic, in most of the situation, it is possible to cure this pneumonia in patients also.
Okay, thank you, sir. So one of the listener has asked regarding the duration of the pneumonia, as because it has been mentioned that this is an acute pneumonia. So, is there any duration?
No. That's why initially I said that whether the terminology is correct or not, because the terminology is used acute pneumonia because we are using this platform as acute illness, acute medicine. And in critical illness books, it is used this terminology as acute pneumonia. Actually, there is no acute pneumonia and there is no chronic pneumonia. So it is better to say pneumonia. That's why initially I have shown acute pneumonia oblique pneumonia. Actually, pneumonia is acute.
So one of the audience have asked, the COVID can be also classified as a community-acquired pneumonia. So why the CAR-65 score is not being used for the COVID-19?
So initially, I have shown that pneumonia has been classified in different ways. That depending where from the patient has acquired the organism, this is community acquired. So this community acquired pneumonia, depending on, we have said that bacterial community acquired pneumonia is mostly Streptococcus pneumonia and other organisms. Definitely this viral disease also community acquired, but we classify this as viral, bacterial for other reasons, for treatment, for transmission, for different reasons we classify in different ways. This is the advantage of classifying disease in different ways.
Thank you, sir. Actually, we are running short
No,
of
no, no.
time.
আমি একটু প্রফেসর নাজমুল যে কোশ্চেন করছে তাকে বলতে চাচ্ছি, আসলে সে বইটা পড়ে নাই। অবশ্যই আমাদের গাইডলাইনে CRB 65 দেওয়া আছে, এবং কখন এটা স্কোর 2 হলে কি মডারেট হবে, 3 হলে সিভিয়ার হয়ে হাসপাতালে যাবে। সো দয়া করে অনুরোধ করব, যে প্রশ্নটা করেছে তিনি যেন একটু বইটা, এই 9 ভার্সনটা আবার একটু খুলে দেখেন।
Thank you, sir. Thank you, Chairman, sir. As because we are running short of time, we can't take any other question. So now, I would like to request our respected Professor Mohammad Zakir Hussain, sir, to have his brief comment on the presentation and on the topic. So, Professor Mohammad Zakir Hussain, sir.
Thank you, Dr. Mahfuz. Today's chairperson of this session, Dr.S.M. Speaker of this session, Professor H.A.M. Nazmul Hasan, sir. Panelist, Professor Raziul Alam. Moderator, Dr. Mahfuz. And host, Dr. Prince Kausar. I am very much delighted to be here as panelist. Today's topic is very interesting and very common, and that is one of the most important respiratory illnesses. My teacher, Professor H.M. Chaudhary, when I was assistant registrar of him in Dhaka Medical College, he used to say, if you know pneumonia, you know all things of respiratory system. That is, pneumonia is such an illness. If uncomplicated pneumonia, appropriate treatment resolves spontaneously. But if there is complication of pneumonia, anything may happen. That is, lung abscess, bronchiectasis, pleural effusion, empyema-thoracis, septicemia, metastatic abscess, massive hemoptysis, respiratory failure, whatnot. So, know pneumonia correctly, you know all illness of it. Today's topic definitely is a difficult topic, and Professor H.M. Nazmul Hasan nicely elaborated it, though very much quickly he elaborated it. I think it will be in the, online, so I am requesting all of the listeners to follow the lecture again and again so that we can learn more and more from today's lecture. I am giving thanks to SCP Chapter Bangladesh for selecting me as a panelist. I am also giving thanks to moderator Dr. Mahfuz. So thank you all. Assalamu alaikum.
Thank you, sir. Thank you, Professor Mohammad Zakir Hussain, sir, for his nice and brief comment on the topic. So, before going to chair, I would like to thank all the thank the speaker, Professor S.M. Nazmul Hasan sir, the panelist Mohammad Zakir Hussain sir, and all the audience who are watching and hearing this session. It's my great privilege to be here as a moderator. And before going to the chair, I'd like to thank all, and I'd like to request our chair to have the final comment and to conclude the session. And I'm going to Professor Tariqul Islam, sir. Sir.
Thank you very much. Really, it was a very interesting topic. But because by 10:30, it is 10:30 now, we have another program. So Professor Nazmul ran little bit faster than the usual because of the time constraint. Otherwise, I think it would have been a very nice one. But I think the slides will be in the YouTube, so you can see it repeatedly. What Professor Jakit told. Uh, I must appreciate Professor H.M. Nazmul Hasan, who is a obviously very uh, senior teacher and senior professor of this country, make the pneumonia very palatable for our listener. Pneumonia itself is acute, no doubt about that. And before COVID, hundreds and thousands of patients usually die every year globally because of pneumonia. This year, COVID took the responsibility, and so we are running after COVID. But before that, flu and other organisms, they usually took part much higher than the usual. As because we have to leave and we have to join another meeting, but still, what Professor Nazmul told, আমি যেটা আরো বাংলায় বলছি যে আপনারা যারা শুনছেন, যারা পরীক্ষার্থীর সামনে তাদের আইওএ স্টেশনে যদি নিউমোনিয়ার একটা ডায়াগনোসিস নিয়ে অথবা তার থেরাপিউটিক ম্যানেজমেন্ট নিয়ে যদি একটা কোশ্চেন আসে, আই থিঙ্ক আজকের লেকচারে আপনারা অনেকগুলো তথ্য সেখানে পেয়ে গেছেন যে কিভাবে ডায়াগনোসিস করতে হবে এবং এর কনভেনশনাল কিছু চিকিৎসা আছে। কমপ্লিকেশন নিয়ে তো বিশাল, নিউমোনিয়ার ভ্যারাইটি নিয়ে আরো অনেক কথা বলা, আরো বেশ কোশ্চেন অ্যান্সার দিস দ্যাট করা যেত বা হয়তো গেলে ভালো হতো। যেহেতু আমাদের ব্যাক টু ব্যাক আর একটা প্রোগ্রাম আছে, সেজন্য আমরা হয়তো একটু কার্টল করেছি। দ্যাট ডাজ নট মিন যে এটা অনেক বেশি কম্প্রোমাইজ করা হয়েছে। এই বক্তৃতাটা বা এই লেকচারটা আই থিঙ্ক ইট উইল বি ভেরি মাচ বেনিফিশিয়াল for all the students, because he did not keep any stone unturned. He has touched every, but he could not stay for long on a slide for proper and adequate description time. But still, the slide itself, they are talking. দিস ইজ ওয়াইড ভ্যারাইটি। একটা নিউমোনিয়া এবং নিউমোনিয়া চ্যাপ্টারে প্রায় ফাইনাল ইয়ারে আপনি বলেন, ফাইনাল ইয়ারে প্রায় 3টা ক্লাস থাকে অলমোস্ট। নিউমোনিয়া পার সি, তারপরে নিউমোনিয়ার কমপ্লিকেশন, টাইপস অফ নিউমোনিয়া, মিনিমাম 2টো তো থাকেই। সো 2 আওয়ার্সের জিনিস 40 মিনিটে উনি যেভাবে বলেছেন, আমি অবশ্যই তাকে এর জন্য মানে সাধুবাদ দিতে চাই। কন্টেন্ট সবই আছে, আপনারা কাইন্ডলি প্লিজ গো থ্রু ওয়ান্স এগেইন অ্যান্ড ওয়ান্স এগেইন। Obviously, I must say that this is one of the brilliant lecture among the acute topic that is being sorted out for the last few episodes. এবং আজকে আমরা হয়তো এখানে আর 1 মিনিটের মধ্যে শেষ করে চলে যাব, কিন্তু আপনারা বাড়িতে যে জিনিসটুকু নিয়ে যাবেন সেটা হচ্ছে আজকের জিনিসটাকে আবার ঝালাই করবেন, আবার দেখবেন। সো রিপিটেডলি ইফ ইউ গো থ্রু দিস, অবভিয়াসলি আমরা মনে করি যে what we are doing, everything for the students, everything for the coming generation of our internal medicine. So with this, I want to conclude, and I must thank Professor Nazmul for this brilliant lecture. Also Professor Jakir, who has joined from North Bengal. He is also a very good organizer, very good teacher, very popular in his area. Also moderator Dr. Mahfuz, and our anchor Dr. Prince. Obviously he is a man behind everything because he is doing all technical issues and everything. And also our listener, viewer, যারা দেখছেন তাদের সবাইকে অসংখ্য ধন্যবাদ জানিয়ে সামনে আবার যে অ্যাকিউট মেডিসিনের ক্লাসটি হবে বা এরকম সেশন হবে, সেখানে সবাইকে অ্যাডভান্স এসসিপি বাংলাদেশের পক্ষ থেকে অন বিহাফ অফ প্রফেসর নাজমুল আমি সবাইকে আবারও দাওয়াত দিয়ে আজকের প্রোগ্রাম এখানেই শেষ করছি। এবং আপনারা সবাই সুস্থ থাকেন, ভালো থাকেন। আল্লাহ হাফেজ, আসসালামু আলাইকুম।
Sadly, we have come to the end of today's program. We have learned so many important and very essential things from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, moderator Sir for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us, especially those who asked very interesting questions. If you joined late or couldn't see the whole program, there is no need to be worried. You can find the whole program on our YouTube channel right after the presentation finishes. Our next health talk on acute medicine will be held on 31st of August, where Professor Abdul Wadud Chaudhry sir will discuss on the topic management of acute myocardial infarction. So, see you all in the next episode. Until then, take care and good night.